Live.
Okay. Good evening, everyone. A very warm welcome to all of you to today's webinar on latest advances in immunotherapy. We are truly delighted to have you join us for this insightful session. It is my privilege to introduce our esteemed program convener, Dr. E. Prasad, Senior Consultant, Medical Oncology at Apollo Proton Cancer Center, Chennai. Sir, I kindly request you to take the scientific program forward. Thank you.
So the immunotherapy had kind of changed a lot of things in the treatment of oncology. So initially, when immunotherapy was available in India, it was quite a very good enthusiasm because we did have some drug which would change the outcomes of the patients. But the enthusiasm was also mixed with the cost issues. So whenever we talk to the patients, we did have a lot of enthusiasm, but end of the day, the prices were so exorbitantly high that many patients were not able to afford it. Down the lane, we do have a few companies which came up. We did have increase in the number of immunotherapy drugs, and few patients were also able to have good outcomes. But recently, there is an explosion in the use of immunotherapy drugs in the field of oncology, not only in the metastatic setting. Now we do have the patients who are eligible for immunotherapy in the adjuvant as well as the neoadjuvant setting also. And this, in fact, had changed the outcomes of many of the surgical interventions and the treatment decisions in many cancers. And this is what we are going to hear from the experts. So we'll be hearing about how did immunotherapy redefine the oncology from Dr. Armugam, who is our first speaker, subsequently followed by the role of NGS liquid biopsy in lung cancer from OneCell.ai. The immunotherapy unleashed in management in NSCLC would be by Dr. G. Raja, Professor of Radiation Oncology, Government Raipeta Hospital. And that would be followed by what do we have in the latest treatment arsenal in the management of esophageal carcinoma by Dr. Prasanna, Senior Consultant, Apollo Magdrichi. What do we have in gastric carcinoma? The immunotherapy role will be spoken about by Dr. Pandithurai, who is professor in medical oncology at Stanley Medical College. And there will be a small panel discussion with all the panelists, and we would close the session. So this would be the day. I would like to call on Dr. Arumugam, the first speaker, to give us an enlightening talk about redefining immunotherapy. Dr. Arumugam, welcome, sir.
Yeah, thank you, Dr. Prasad. Thank you for the introduction. Please project the slides, please.
Okay, sir. 1 second.
Thank you. My today's topic for the discussion is redefining immunotherapy. So already Dr. Prasad highlighted the importance of immunotherapy as of now. So we are moving the era of chemotherapy to immunotherapy now. So most of the cancers are having in various kind of indications to use immunotherapy. So I'm going to talk on this following topic. One is the PD-1, PD-L1 inhibitor landscape and drug tislelizumab, the profile of tislelizumab, and the clinical evidence landscape in NSCLC, esophageal squamous cell carcinoma, and gastroesophageal junction carcinoma, and safety profile. And we have to conclude about the tislelizumab. Next slide. So the approved PD-1 and PD-L1 antibodies, if you are seeing this slide, so various indications are now available for the immunotherapy usage. So nivolumab was the first PD-1 inhibitor approved in 2014 for melanoma. And now there are around 11 PD-1 and PD-L1 inhibitors approved globally. Various indications like NSCLC, gastroesophageal junction tumor, urothelial carcinoma, classical Hodgkin's lymphoma, esophagus squamous cell carcinoma, hepatocellular carcinoma, and nasopharyngeal carcinoma, all MSI high tumors, all these are having various indications. So, like Pembro, Nivo, Atezolizumab, Durvalumab, Tislelizumab for NSCLC, and gastroesophageal junction tumors, Pempro, Nivo, Tislelizumab has indications in gastroesophageal junction tumor and gastric cancer. Atezolizumab, Nivolumab, Pembro, Durvalumab, Avelumab, and Tislelizumab in urothelial carcinoma. And in classical Hodgkin's lymphoma, Pembrolizumab, Nivolumab, Sintilimab, and Tislelizumab. And esophageal squamous cell carcinoma, we have Pembro, Nivo, Sintilimab, and Camrelizumab, and the Tislelizumab. In hepatocellular carcinoma, Pembrolizumab, Nivolumab, Atezolizumab, Durvalumab, Sintilimab, and Tislelizumab. MSI high tumors, all MSI high tumors can be treated with the Pembro and Tislelizumab, and in nasopharyngeal carcinoma, Toripalimab, and Tislelizumab has indications. So next. So overview on tislelizumab. What is the difference between all other PD-1, PD-L1 inhibitor with the tislelizumab? It is a humanized IgG4 monoclonal antibody with high affinity and a binding specificity for PD-1. So the special characteristics are this drug blocks the PDL1 and PDL2 to PD1, and is differentiated by its unique binding epitope, binding kinetics, and distinctive binding orientation to PD1. The recommended dose is 200 milligram once in 3 weeks, and it is development plan is global development as monotherapy and in combination of solid tumor and hematological cancer. More than 20 potentially registration enabling clinical trials in 35 countries. And this tislelizumab received patients is around 13,000 plus patients. More than 750,000 patients are treated commercially. So next slide. So the disease one has a broad global clinical development program. So various indications from the nasopharyngeal carcinoma, lung cancer, gastric, hepatocellular carcinoma, urothelial carcinoma, and the tumor MSA high tumors. So approved indications, approved in what are all the countries they have mentioned, and the all are key global trials with either phase 2 or phase 3. Mostly these rational studies 302, 306, 303, 305, 301 are the phase 3 studies. Next slide. So ongoing clinical trials with the tislelizumab include the novel combinations. So the we can check the tumor type and the study design, and almost all the drugs are in the phase 1, phase 2 trial. So data suggests that tislelizumab may be an ideal candidate as a backbone of combination therapy with the chemotherapy or targeted treatments. Trials going even with novel bispecific antibodies. Next is the tislelizumab profile. It is a next slide. So the structural advantage, overall structure of the PD-1 tislelizumab FAB complex was reflected on this picture, and the tislelizumab has a distinctive binding orientation to PD-1, and have been identified. There are various regions are identified unique binding epitopes of the tislelizumab. And the binding orientation to PD-1 differs to that of pembrolizumab and nivolumab, as well as the binding kinetics also. So the binding surface of tislelizumab on PD-1 overlap largely with that of PD-L1, leading to complete blockade of the PD-1 PD-L1 interaction. That is about occurs about more than 99%. So the Pembro and Nivo with a different binding orientation showed a partial PD-L1 blockade. So the mechanism of action of anti-PD-1 monoclonal antibody with the FICR binding site. Next slide. So mechanism of action, the anti-PD-1 monoclonal antibody with the FCYR binding. So this tislelizumab is constant. You can see this third one, the anti-PD-1 PD-1 antibody without FICR. This is the main region of tislelizumab action. Next slide. So an anti-PD-1 antibody without FICR binding may allow T cells to remain activated and maintain the effector functions. So minimal binding of the anti-PD-1 to FCYR abrogates the ADCP cell clearance. Next slide. So the advantages are it has a half-life of approximately 30 to 80 fold, excuse me. Am I audible?
Yes.
Hello, am I
Yes, sir.
audible? Yes. Yeah.
Yes,
Okay.
sir.
Yes, sir.
So it has a half-life of approximately 30 to 80-fold longer than that of pembrolizumab and nivolumab respectively. And in the preclinical model, tislelizumab demonstrated a high target affinity and slow dissociation rate from the PD. So the same way it has a lower half maximal inhibitory concentration IC50 value, thus having stronger anti-tumor activity. But the same IC50 values of Pembro and Nivo are 1.3 to 3.5 times higher compared to the tislelizumab. So next is the next slide. So the concordance between the scoring system. Next slide. So the scoring methods are TAP and CPS score. So the TAP score is usually used for the research, and it has some secondary merits. But CPS score is the universally accepted for immunotherapy. Next. The safety of and summary of the adverse events. Next slide. So the treatment-related adverse event and the discontinuation rate with the tislelizumab monotherapy or in combination with the chemotherapy appears to be consistent with that of the other IOs. So comparing the other immunotherapy, the same with the discontinuation rate and also treatment-related adverse events. Next slide. So there were no statistically significant differences between tislelizumab plus chemotherapy and any comparator treatment with more than or equal to grade 3 treatment-related adverse event. You can see the chemotherapy, tislelizumab plus chemo, pembro plus chemo, tislelizumab plus chemo. So all there is no statistically significant differences. Next slide. So the tislelizumab demonstrated a statistically significant reduction in the risk of experiencing more than grade 3 treatment-related adverse event compared with atezolizumab, pembro, and chemotherapy. This one favors the use of tislelizumab. Next slide. So the major adverse event with in the rationale 302, you can see the this AST is increased, anemia, hypothyroidism, decreased appetite, diarrhea, and the WBC count decreased. That is neutropenia, neutrophil count decreased. So all these things we can compare to with the others. The tislelizumab showed a favorable safety profile compared with the chemotherapy. The guideline recommendations are the next slide. So NCCN recommendation summary. So esophageal cancer, the category 1 preferred regimen, first line in combination with the 5FU plus oxaliplatin or cisplatin for PD-L1 CPS score of more than or equal to 5, HER2 negative adenocarcinoma of esophagus. And the first line in combination with the 5FU plus oxali and cisplatin for PD-L1 CPS score of more than or equal to 1 esophageal squamous cell carcinoma. So category 1 preferred regimen, second line or subsequent therapy as monotherapy. For nasopharyngeal carcinoma, the category 2B other recommended regimen, And first line are recurrent metastatic nasopharyngeal carcinoma in combination with the cisplatin and gemcitabine. Likewise, hepatocellular carcinoma, first line systemic therapy as a monotherapy. Then gastric cancer, category 1, preferred regimen, first line in combination with the 5-FU oxaliplatin or cisplatin for PD-L1 CT score of more than or equal to 5, HER2 negative gastric cancer. So the alternative, next, the dosing options are the flexible dosing and the schedule options are available with the tislelizumab. Next slide. So either with 150 milligram once in 2 weeks or 200 milligram once in 3 weeks, or we can give even 300 milligram once in 4 weeks. The conclusion, the tislelizumab is a humanized IgG4 monoclonal antibody with high affinity and binding specificity for PD-1. So tislelizumab blocks mechanism of action. The tislelizumab blocks the binding of PD-1 and PD-L1 and L2 to PD-1. So inhibiting PD-1 and restoring T-cell mediated anti-tumor response. And the tislelizumab is differentiated from Pembro and Nivo by its minimal binding to FcYR and unique binding epitope, binding kinetics, and distinctive binding orientation to PD-1. Preclinical era, the tislelizumab has demonstrated high target affinity and slow dissociation rate of PD-1 with a 30 to 80-fold longer half-life. And the clinical efficacy and safety, besides multiple other phase 3 clinical trials showing positive results in the neoadjuvant NSCLC, SCLC, gastric and gastroesophageal junction and hepatocellular carcinoma setting, and phase 2 trial showing a positive results in urothelial carcinoma and MSI high tumors. So the approvals are the trastuzumab is approved in India in second line esophageal squamous cell carcinoma and first line and second line squamous and non-squamous NSCLC by the EMA and the FDA for second line esophageal squamous cell carcinoma and first line gastroesophageal junction tumors. So NCCN has recommended tislelizumab in 4 different tumors. Category 1 preferred in second line esophageal squamous cell carcinoma, first line esophageal squamous cell carcinoma, gastric or gastroesophageal junction, and first line hepatocellular carcinoma. Category B2B recommendation in the first line and subsequent in nasopharyngeal carcinoma. So the recommended dose is 200 milligram once in 3 weeks, and other doses are also available. Thank you. Thank you. Over to you, Dr. Prasad.
Thank you so much, sir. That's a wonderful talk about what do we have in the treatment of immunotherapy. And may I now request the team from OneCell to talk about the role of NGS and liquid biopsy in lung cancer.
Yeah. Thank you so much, Dr. Prasad. Hi, team. I'm Dr. Sandhya. Let me just share my screen and my slide, and then we can take it up ahead from there. Hope I'm audible clearly.
Yes.
Yes, ma'am.
Okay, thank you so much. Thank you for confirming. Is my screen visible?
Yes, ma'am.
Okay, thank you so much. Great. So it was a good talk that we started with. So let me just continue on the topic that has been given. So just a small introduction. I work as a principal scientist, clinical genomics in OneCell. And this talk that we will have today for the next 30 minutes is going to be focused on precision oncology, which is driven by NGS into the lung cancer. So just a disclaimer, this content of the presentation is private because we are going to be having some kind of patient data that is going to be there and some kind of AI-assisted tools we have used to prepare this presentation. So let me just begin by introducing the company. So we are about a little over 24 months commercially in the market today, established about 5 years back, but 3 years was completely focusing on R&D. And only from the past 2 months have we been commercially launched in the market, and we have processed over 30,000 patient samples till date. our service is not limited to being a commercial aspect. We also do a lot of R&D. As we go ahead in the presentation, it will become more clearer. And we have published with ASCO, ESMO, ISLB, a lot of posters and presentations. As of 2025, we have over 65 abstracts and posters with ASCO, over 9 with ESMO, right? And if you focus on the kind of abstracts and the kind of R&D that OneCell is involved in, you will see that we do not do the normal population kind of study, but we study the precision oncology drivers in detail, including your circulating tumor DNA aspects, single circulating tumor cells, distribution of protein markers on individual CTCs. Even in the year 2025, if you see in ASCO, we had over 19 accepted abstracts that have gotten published. So that is the breadth of our research that we do in precision oncology, because we believe that we need to truly personalize cancer management today, right? Our products and services are not a huge portfolio, because we believe that though one size doesn't fit everybody, it is important to know that targeting certain questions can be possible when we have certain services catering to the clinical challenge. So India is a price sensitive market, which is a known aspect. So for those who are looking out for those guideline recommended genes or that hotspot testing kind of services, we have the OncoTarget. And for a comprehensive genomic panel where we are looking at an aggressive disease, a metastatic setting, or cancers of unknown primary origin, or cancers that have dual primary origin, those kind of cases, we do it with our comprehensive genomic profiling, which is OncoIndex. And also we have a portfolio that is called OncoMonitor, which is used for minimal residual disease monitoring. So we have services catering to specific clinical questions and demands. So precision medicine, when do we incorporate molecular profiling, and will it transform global cancer care today? Yes, we know that, because the technology is rapidly evolving, right? From the point of having Sanger sequencing, PCR, RT-PCR to microarray, today we are talking about NGS, which can churn GBs of data. The costs are falling. Better outcomes and value can be provided only if we understand what to do with the data. So we are in the data world today, and precision oncology is not behind there. So the question is, should every cancer patient be profiled? And should we profile both tissue and liquid? So these are the few questions that we will try and answer today in this presentation using the backdrop of the lung cancer. So metastatic setting is one of the major causes of death, more than 90% of the cancers, right? That is because when we do a biomarker-based testing, our clinical decisions rely only on either we do single biopsy or we do liquid biopsy, which is plasma-based. So what is the drawback when we do only these kind of approaches is that we miss spatial heterogeneity. Like a metastatic lesion could be in the liver, it could be also in the brain. But if I do a plasma-based assay, I'm going to miss something that is causing the brain lesions, right? That spatial heterogeneity I'm going to miss. Secondly, compartment-specific resistant mechanisms have also been noted, which can be plasma-specific and tissue-specific restricted clones. Thirdly, microenvironment-driven adaptations as to what is shaping the tumor evolution. So the challenge that we have is incomplete tumor profiling can lead to suboptimal therapeutic decisions, causing inevitable resistance. And how can an NGS-based service help in all that scenario in a single setting rather than having a sequential testing is what we will see. So at OneCell, what we do, we customize our gene panel, right? We do not have off-the-shelf panel. That is the reason we had a strict R&D only job that we did 3 years. So we have our own panels where we have designed for DNA, RNA, as well as whole transcriptomics. We customize constantly technical optimization, right? The guidelines are improving. The scientific knowledge and the landscape, molecular landscape is improving. So also the NGS platforms that are coming up. So constant technical optimizations is very important. And believe me, in the 2 years that we have been in the market, we are already at the version 4 of our commercial panel. We have enhanced bioinformatic data systems. As he said, it's very important, right? The drivers could be, if they are germline, sure, you can easily catch in a low depth. But when it comes to NGS, it is also very important that we have to find out resistant mutations, emerging clones, the molecular evolution of the cancer in the landscape. All of this requires in-depth sequencing. The breadth and the depth of the NGS panel matters. That is how we enhance our bioinformatic analysis, including our sequencing depth. And we also use a lot of AI to help us in interpretation, and then use a manual intervention to confirm it. So we have a great quality coverage of more than 10,000x. We have a TAT of 10 to 12 working days, and we have an interpretation team that helps in the pre-test counseling, in the post-test counseling, including people like me and my team, which are a team of genome scientists. So in lung cancer, or any cancer for that matter, where all can you use a molecular test, and in what all continuum care it can be used? So it can be done in the neoadjuvant stage itself, where you use ctDNA to find a baseline, right? Of course, it may not work if it is a localized cancer, but if some amount of metastasis has been suspected, a ctDNA baseline level can be taken. And post the neoadjuvant treatment, which could be surgery or chemotherapy, you could do an MRD with our OncoMonitor test. And further, for molecular genotyping, either using the tissue that has been extracted from the surgery or the liquid biopsy in case the ctDNA is positive, we can continue to study the changing molecular landscape continuously, and also do the tissue liquid normal match analysis in case the cancer becomes excessively aggressive or stops responding to the standard of care. So molecular testing is never one size fits all. It is not to be used at early stage or late stage. Test and technology at multiple price points is available throughout the continuum of care for the patient, and applying the test at the right time is where the beauty of precision oncology can be put to use. So what are the current limitations when we measure disease burden or relapse in solid tumor patients? First is imaging. Imaging has got a limit of detection, right? It has the inability to detect micrometastatic diseases. Secondly, clinicopathological characters can be not always correlated to the outcomes. Thirdly, serum-based protein biomarkers also have a very, very low sensitivity and specificity. So can I use ctDNA to make that clinical decision making? Yes. If you see, there are multiple studies that have shown that ctDNA, in case of lung, since we are focusing in lung this time, lung, if you see, ctDNA-based analysis can give you an average lead time of close to 5 months before the disease even starts showing up in imaging. And that's why ctDNA-based continuum of monitoring is recommended when it comes to lung cancer. So can I use it for neoadjuvant response monitoring? Yes, it can assess early response for de-escalation or escalation of the treatment, right? This treatment escalation, de-escalation using ctDNA has also been reported in multiple clinical trials for colon cancer. We have post-surgical MRD, which can be used to optimize your adjuvant treatment. It can be used for recurrence monitoring, and also it can be used to track the response or non-response to the multiple clinical management strategies that is used. So we believe actionability, that is acting if there is a driver mutation or any targetable agent, and resistance, studying both together in a same test becomes very, very important, because that gives you the maximal advantage of a molecular testing. Why it is also necessary? Because of tumor heterogeneity, right? So when you take the tissue from the cancer, the resected cancer, and when I take the liquid, when I compare both, I have cases where I show a lot of heterogeneity, right? So your tissue becomes like a historical data, a historical molecular data, while the blood or the plasma or the liquid biopsy molecular setup kind of becomes your dynamic profiling baseline. So also, when we say tissue is today becoming an issue. That's how we want to put it. Because if you take a fresh tissue and I take the liquid biopsy, there is 100% concordance if you see if they're tested less than 2 weeks apart. So molecular findings in tissue is going to mirror your molecular findings in the liquid biopsy. But as the time difference between extracting the both increases to more than 6 months, you see there is a 40% drop in the concordance rate, showing that the tumor that is rapidly evolving and changing the molecular landscape to survive in the blood or the liquid biopsy is very, very different from the native tissue. There is also a study that did ctDNA analysis of about 255 samples of lung cancer patients, 255 samples from 40 patients who have been treated with curative intent surgery, stage 1 to stage 3 lung cancer. In these patients, if you see, 94% experienced recurrence, and ctDNA was detected in the first post-treatment blood sample, indicating that minimal residual disease could have been identified. And post-treatment also, the radiographic progression preceded 72% of the patients by about 5.2 months, and 53% of the patients harbored a ctDNA profile that could be used to treat them with tyrosine kinase inhibitors or immune checkpoint inhibitors. And that is the benefit of using ctDNA for serial monitoring even in lung cancer cases. So I will just present a few cases across the different continuum so that the benefit of NGS and precision oncology and liquid biopsy becomes more easily apprehensible for the crowd here, right? So this is the first case. In case I'm fast, please feel free to tell me about that. So I'll continue with the case. Okay, I will just take this as a yes, and I'll continue. So if you see a 50-year-old male, case of lung carcinoma, HPE on the May 2025 of the left scapular lesion biopsy suggested metastatic squamous cell carcinoma. The case came to us. We did a tumor normal match, wherein we took the tumor tissue, we took the liquid biopsy, if you see plasma, the blood, and the tumor tissue that was resected, and we did a normal match. So we had the genomic DNA, that's from the white blood cells. We had the plasma ctDNA and the tumor DNA from the tissue. If you see, apart from TP53, which was there, we also found multiple other alterations, including EGFR amplification and the entire FGFR pathway that is being activated. So next, what it also, if you see, we did the tissue RNA over here as well, right? If you see RNA, there are some overexpression or exceptionally expressed genes that we found for SERPIN1, MALAT1, and PMIP1. Beyond that, we found one CTC in the blood, nothing over here in the immuno-oncology setting. The PDL1 was found in tissue at a TPS of 2%. Now, what does this entire comprehensive information help the doctor treat this patient? So what we did is that molecular profiling shows that it is an aggressive disease because we have TP53 and CDKN2A. There is also an EGFR amplification which was detected, showing that EGFR TKIs have limited impact in this case. Further, we had co-occurring TP53 and CDKN2A with CCND1. So shows that there will be reduced responsiveness to both targeted and immune therapies. Amplification of FGFR entire pathway is there. That can also confer resistance again to EGFR directed. And PDL1 is about TPS 2%, low immunogenicity and limited benefit from immunotherapy, monotherapy at least in this case. And there are certain high expression genes that show that the cancer is in the pro-survival mode, metastatic mode, and human immune evasive microenvironment. So based on entire portfolio of molecular findings, we were able to recommend that chemoimmuno is probably a better option to begin with in this patient. And post 3 months, we could probably continue surveillance with a liquid biopsy. Now, this is the advantage that a comprehensive genomic profiling did when we use a tumor normal match setting. So if the patient would have recommended a smaller panel in this case, just a lung cancer panel for EGFR, MET, RET, ROS1, ALK, it would have come negative because there are no EGFR drivers over here, right? So the doctor would have immediately gone for the chemo immuno combination because immuno would, or just the IHC combination, right? But then using that kind of understanding of where the exact broad spectrum is there and how the future of the disease can progress is possible only when we use a comprehensive setting. Let me go to the next case, which is again a lung carcinoma. The problem statement over here is when treatment resistant clouds the way in EGFR mutant lung cancer, can longitudinal monitoring guide the next therapeutic step? So in this case, she was a 62-year-old female. EGFR mutation analysis was done by PCR, exon 21 mutation we got. Initially, she got treated with pemetrexed, carboplatin, gefitinib. She continued to develop a disease progression. The PET-CT was done in February 2025. There was interval increase in the number of bilateral lung nodes. Fourth line therapy switched to afatinib from Feb 2025. July 2025, she got brain metastasis, planned whole brain radiotherapy, and last cycle was done in August 2025. Post this, the doctor sent us the blood sample for OncoMonitor test. That is our longitudinal monitoring test. So in this case, if you see, we found ctDNA to be positive, CTCs to be positive, showing that there is a metastatic potential and there is an aggressive disease. Further, when we did the molecular profiling of the ctDNA, we found EGFR L858R with T790M, showing that the resistant mutation has developed. Also, what is interesting to note over here is that we also found an RB1 mutation over here in this profiling, which shows that transformation of NSCLC, the non-small cell lung cancer, to small cell lung cancer is en route, and this histological transformation has to be taken into consideration in future while treatment. And real-time surveillance becomes very important. So if you see a single blood test, when done at the right time, in this case, because the treatment resistance had developed, the patient had developed brain metastasis, the doctor thought we could do a blood analysis and check for OncoMonitor what is the case. We were able to design and this entire molecular spectrum and give it to the doctor to help the treatment further. So this is how our monitoring has been able to aid in one of the cases of lung cancer, right? So we know now that metastatic cancer is a complex system. It is not a single lesion. So selection is very important. So different organs impose different selective pressures. Resistance of the therapy shapes evolution in difference in each site. There are some sites that act as sanctuaries like the central nervous system. It's like a sanctuary for the cancer. Metastatic cancer is what we say as molecular scientists, and progression others can act as an evolutionary hub, like your liver. Your liver is generally the evolutionary hub where the cancer, once metastasized to liver, rapidly transforms in its molecular shape and form. So the key challenge is that we often sample the wrong compartment. So liquid biopsy, we all know that it is blood. So everybody understands tissue. We say liquid biopsy is blood. But is blood always the right compartment to study? Proximal sampling is what is important. So we at OneCell have done the study with all forms of liquid biopsy in different cancer types and have been able to help doctors identify, if you choose to do a liquid biopsy, which biopsy becomes more effective at what stage for that particular patient. So we have been able to do our comprehensive genomic profiling using cerebrospinal fluid in case of brain and leptomeningeal metastasis, urine for kidney, bladder, and bone metastasis, saliva for head and neck, pleural effusion for lung and pleural fluid, and ascites fluid also for peritoneal and ovarian spread. So detectability is usually driven by tumor burden, and the proximity to the primary tumor is what drives the entire molecular spectrum, right? So what are the three fundamental blind spots which we can address when we study these different biofluids is that tumors in different anatomical locations, they shed different molecular signals, right? So the blood tissue barrier or the blood-brain barrier, it limits the tumor DNA from coming into the plasma. The bone and pleural metastasis also shed DNA unevenly, and the local tumor microenvironment also affect the DNA release. So a plasma liquid biopsy may miss if the resistant mutations are present in the bone lesions or in the pleural ascitic fluid or in the cerebrospinal fluid, right? And plasma EGFR testing, it's a case that we did, like we did the plasma EGFR testing for the patient where EGFR was negative. But for the same patient with brain metastasis, when we did the cerebrospinal fluid, we found it was biopsy positive for T790M, and another case for C797S. So the takeaway over here is one biofluid will never talk about the whole body tumor biology. Secondly, the spatial plasma is not equal to CNS, not equal to bone, not equal to pleura. It means genotype alone will not fully explain your phenotype, right? Having the same genomic mutation in 3 different patients will never guarantee the same tumor behavior or drug response, right? That is also because the tumor microenvironments will be different for the patient. The lineage plasticity can be different. There are non-genetic resistance mechanisms that can come into play. And 2 tumors with identical mutations will also show different growth rate, different resistance patterns, right? There could be like in EGFR mutant lung cancer, there is one lesion that responds to TKI. Another progresses by bypassing the EGFR pathway by probably developing a HER2 amplification, right? So that is why your genotype will never explain the full phenotype of the disease. And the third is mutations and behavior will not always match, right? That is because of the temporal heterogeneity. Evolution under therapy is poorly tracked. Cancer evolves over time. Therapy resistance develop as subclones. Plasma may probably even lag behind in real-time tumor evolution because resistance appearance may be transient, may not be shedded too much, or shift between 2 different clones. That is why it is important to have a real-time dynamic tracking, and resistant mutations appear months before radiologic progression. That is why having a liquid biopsy-based tool becomes very, very important. So This is one of the papers which we have published from OneCell. If you see, we have done ctDNA beyond blood, where we have used pleural fluid in lung cancer patients only. And we have found out that both plasma and pleural fluid concordant mutations are there in 86% of the cases, but in 14% of the cases, the plasma was negative, but the pleural fluid was positive for actionable alterations. And that is why identifying the right biopsy fluid becomes also very important. Another case again we saw is cerebrospinal fluid. This is also our publication only, where cerebrospinal fluid ctDNA and CTCs based molecular analysis highlighted how important is sample proximity. So in this case, if you see cerebrospinal fluid DNA, we had 45% variation, while blood had only 40%, roughly 36% NCC and actionable alterations, indicating that cerebrospinal fluid is a promising alternative, albeit difficult to procure multiple time points from a patient. But if done once properly, it can probably aid in easing out the clinical challenge at that particular time point. So this is the last case that we have, a very complex and interesting case that talks about this blood-brain barrier and why proximal fluid becomes very important. A 64-year-old female, she had EGFR exon 19 deletion positive, first-line osimertinib given for 2 years, she was stable. Progression happened, she acquired the C797S. Further, the clonal evolution was done, that is ERBB2 amplification, treated with trastuzumab deruxtecan. The crisis came when the patient started developing neurological symptoms like headache, photophobia, MRI confirmed leptomeningeal disease, right? So the MRI brain scan showing specific ring enhancing lesion in the frontal lobe. It confirmed that disease had progressed to the brain. So in this case, what happened is that we asked the doctor to give us both the plasma and the cerebrospinal fluid of the female. If you see, we collected both. In the plasma, if we had tested alone, if you see, there was nothing. It was NMD. There was no actionable alterations, and that becomes a blind spot. But in this case, the cerebrospinal fluid, if you see, we found actionable alteration with EGFR and HER2, multiple drivers that basically makes a CNS metastasis a possibility, absent in blood, but dominant in cerebrospinal fluid. So this is what is important to understand. Biology dictates detectability. There is a leptomeningeal phase and then a parenchymal phase that occurs later, right? So in leptomeningeal phase, your CSF is positive and plasma is negative. But when the disease progresses to the parenchymal state, the plasma becomes positive and the CSF becomes negative. So recurrence in parenchyma, the sheds very differently as compared to leptomeningeal. And this monitoring is required to know where to look exactly, even in brain metastatic cases. So what happens over here is that since we found dual alteration of ERBB2 and EGFR, we know that ERBB2 is a bypass mechanism for EGFR pathway. And that is why differentiating between ERBB2, also mutation and amplification, becomes difficult. And without CSF, this patient would have remained on ineffective systemic therapy. So we followed up this case, continued. So as told from the leptomeningeal disease, there were parenchymal brain lesions that came further in October 2024. Follow-up MRI showed that, and she continued with SBRT treatment. And after that treatment, we did again the same proximal sampling of blood and CSF. If you see in this case in CSF, no ctDNA was found, while the blood continued to show the EGFR drivers, but the ERBB2 had vanished. The clone containing the ERBB2 driver had completely vanished. She came back to having the EGFR classic exon 19 deletion. So current status, December 2024 was the last follow-up we had. She was stable with just intermittent headache. The CSF examination continued to be negative for malignant cytology. And this paper we also published with the Journal of Liquid Biopsy with the doctors who were present and helped us with the clinical details and stuff like that. So in summary, if I have to end this presentation, multidisciplinary evaluation is very, very important today. Like molecular findings should be reviewed by a multidisciplinary team to guide effective therapy. Just like the cancer, the entire landscape of cancer is becoming aggressive, it is becoming more challenging. Multiple treatment options are out there. How to get to the perfect treatment becomes very important. How to escalate the treatment, when to de-escalate the treatment becomes very important, because the line is very thin between managing the quality of life of the patient, the side effect of over-treatment, or the risk of under-treatment, right? That thin line has to be maneuvered, and if used an appropriate precision oncology test, believe me, that line can be managed with evidence. So there is a potential for combining therapies and also for monitoring with liquid biopsy to evaluate treatment response, detect emerging resistance mutations, and timely therapeutic adjustments. So that's all I have from my end. Thank you so much for your time and attention. If there is any questions, probably I can just take it now, or Dr. Prasad, we could probably go to the next talk as well. Um, no questions, then Dr. Prasad, we could probably go to the next topic. Thank you so much for your time and attention.
Thank you, Dr. Sandhya, for the excellent session. Now, I would like to invite our next speaker, Dr. R. Prasanna, Senior Consultant, Medical and Hemato-Oncologist at Apollo Specialty Hospital, Trichy. Sir, we are honored to have you with us. I kindly request you to please begin your session.
Could you see my slides?
Yes, sir.
Yeah. Good evening. At the outset, I'd like to thank my friend Dr. Prasad and Glenmark Oncology for giving the opportunity. So today we are discussing about immunotherapy molecules, and there is a tsunami of immunotherapy drugs available right now for the armamentarium usage for the oncologist. So I'll be discussing mainly about the esophageal cancer. And we know that tislelizumab is a unique IgG4 monoclonal antibody with high affinity and binding specificity for PD-1, and it has been highlighted by Dr. Armugam very well. So let us skip. And yes, we have a wide range of global clinical development program and also the indications, various indications approved by various agencies across the globe. And diving into the esophageal cancer, it is one of the deadliest cancer that affects the mankind. And among males, it is among the top 5 cancers, especially in India, the third most common malignancy, again attributed to smoking and alcohol. And it is highly mortal. And as we know, it is more common in men. And 85% of esophageal cancers are squamous histology. And most of them, nearly 40% of esophageal squamous cell carcinoma would be at the metastatic stage. And the rest would be most commonly the stage 3 or unresectable malignancy. So the 5-year survival rate of squamous cell esophageal carcinoma will be roughly 20 to 25%. And when a patient presents with a stage 4, it is just less than 10%. So we know the difference, 85% squamous cell, it can occur typically in the upper and middle third of the esophagus. And probably more and more young patients are now being affected with squamous cell carcinoma, again, because of smoking habits and also alcohol usage. And it has a very poor prognosis. And whereas an adenocarcinoma usually occurs in obese and Barrett's esophagus predisposition, most commonly in the lower 1/3 of the esophagus or Golgi junction tumors, and usually occurs in older patients. And again, this has a very poor prognosis. So let us dive into the clinical trial data. We have the rationale trial 306. We have tislelizumab plus chemotherapy versus placebo for advanced esophageal squamous cell carcinoma in first line. So this is a global trial. The beauty about the trial is around 75% of the patients were Asians, especially with China and Taiwan mainland. And the rest of the world, probably the Europe, Oceania, and North America constitutes about 25%. So 162 sites of 16 countries with 649 patients were studied. The study design was either typically unresectable or metastatic squamous cell carcinoma of esophagus. Patients were chosen for tislelizumab 200 milligram every 3 weeks, along with the investigator chosen chemotherapy. The chemotherapy arm was cisplatin 5FU or even platinum with paclitaxel. And again, the baseline PD-L1 status was studied. Usually the TAP score, again, coherence with the CPS score. TAP score more than 10% and also patients with TAP score less than 10% are also studied, 50-50%. And the endpoints would be OS, and also the secondary endpoints would be PFS and ORR, and also the DOR. So when it comes to the efficacy, the median overall survival with tislelizumab and chemotherapy was the best, 17.2 months versus 10.6 months with the placebo with chemotherapy arm. And the p-value is significant, and also the hazard ratio is 0.66. So it signifies a 34% reduction in the risk of death with the advantage of OS benefit of 6.6 months. And when it comes to the PFS benefit, yes, the median PFS was 7.3 versus 5.6. Again, the hazard ratio is significant, 0.62. And the PFS typically improved with the tumor response and also more durable with the tislelizumab with chemotherapy arm. And when it comes to the safety and tolerability, tislelizumab with chemotherapy, it does not increase the toxicities, and more manageable toxicities, especially the grade 3 toxicities were very less. So tislelizumab is equivalent to other immunotherapy drugs in this portfolio. So next comes the rationale 302 trial, that is tislelizumab versus chemotherapy in advanced esophageal squamous cell carcinoma in the second-line setting. So again, the study set was tislelizumab versus the chemotherapy of investigated choice. The usual second-line chemotherapy in squamous cell carcinoma would be a Taxol or even an irinotecan. And again, it was divided with TAP score less than 10% or more than 10%. And the primary endpoint was OS with more than 10% TAP, or PFS and ORR. So again, this tislelizumab showed a better OS benefit, especially when the TAP score is more than 10%, probably 3.5 months additional OS benefit, and also the 46% reduction in the risk of death. When it comes to the overall patients, irrespective of TAP, tislelizumab added at least 2.3 months to the OS benefit and 30% reduction in the risk of death. So the idea is that tislelizumab provides benefit irrespective of the TAP score in the second-line setting. So tislelizumab was associated with greater ORR, as we know, and nearly 52% the overall response rate versus 25% with chemotherapy arm, and more durable response than chemotherapy. So again, very manageable safety profile, and patients tolerated tislelizumab very well. And so this is the whole indirect comparison of first-line therapy in esophageal squamous cell carcinoma. A variety of immunotherapy molecules available right now. We have pembrolizumab based on the KEYNOTE trial, which has probably the median OS benefit of just 3 months. And the Checkmate 648 with nivolumab, they have OS benefit of again 3 months. The Jupiter trial with toripalimab has a median survival of 6 months. And certain drugs are not available in India. Sintilimab and camrelizumab is not available. But Astrum, again, serplulimab is we have in India. It gives an overall survival of at least 3.5 months. So altogether, the indirect comparison in first line, probably the rationale trial 306, the tislelizumab scores better, probably nearly 6.6 months of median OS benefit, and also the cost effectiveness, and irrespective of the TAP score, even when the TAP score is more than 10%, it has the best benefit. So this again ends up with the ESMO guidelines. We know that PD-L1 testing is essential, and as of today, what we follow is more than CPS more than 10%. We have pembro with chemotherapy. TPS more than 1%. We have Nivo with chemo or IO combination. And as I said, PD-L1 TAP score of more than 5%. We can combine tislelizumab with chemotherapy. And also in second-line setting, we can use tislelizumab and also the other immunotherapy molecules as well for esophageal squamous cell carcinoma. And this is in second-line comparison. We compare the rationale 302 trial versus the KEYNOTE 181 with pembrolizumab. on Attraction 3 trial, that is nivolumab in the second-line setting, with the median OS benefit of nearly 8 to 10 months. So all these molecules will have a median OS benefit of 2 to 3 months in the second-line setting. So tislelizumab is far better when compared to the pembro and nivo, even in second-line setting. So thank you so much for your patient listening. Thank you. Over to the moderators.
Yeah, thank you, Prasanna, for the wonderful presentation. So can we have the questions in the last, please? And can I call Dr. Pandidurai for the next session? Dr. Pandidurai, sir, are you there?
He was there, sir. I'll just check.
Yes, sir.
Yeah.
Let me share my slides. Is my screen visible?
Yes, sir.
Yes, sir.
Thank you. Super. At outset, I thank Dr. Prasad, who is my senior, and the organizers for giving me this opportunity. So I joined lately, so because I don't know what sir will think about. Okay, anyway, so I am going to talk about the role of tislelizumab in gastric cancer. So this is the outline which I am going to talk. So inhibitor landscape and tislelizumab profile and clinical evidence landscape and conclusion. So these are the approved indications for PD-1 and PD-L1 antibodies till now. From 2019, where the first melanoma PD-L1 inhibitors were approved. So this shows the various PD-L1 and L1 inhibitors available and various approvals in various countries. So tislelizumab is a humanized IgG4 monoclonal antibody with high affinity and binding specificity. So it has a high affinity binding profile, and the binding dynamics is also different from other PD-1 inhibitors like pembro and nivolumab. Pembrolizumab and nivolumab. So these are the key global trials which led to the approvals. Like these are the phase 3 trials which are in gray. So I am going to talk about the gastric and gastroesophageal first line rational 305. So these are the structural advantage of tislelizumab over the pembro and nivo. So it leads to complete blockade of PD-1 and PD-L1 due to the binding profile and the affinity profile. So which leads to the complete blockade of PD-1 and PD-L1 interaction nearly up to 99%. Whereas the pembro and nivo which has the blockade interaction of 80 to 81%. So this is the mode of action, as you all know. Just I am skipping this slide. And the important thing to mention here is the bioengineering of the FC portion of the antibody, which lead to delayed clearance of the monoclonal antibody by the macrophage. So this is the same slide. So in preclinical models, tissues may demonstrate high target affinity and slow dissociation, which leads to 30 to 80-fold half-life increase. And there is a inhibitory concentration, half maximal inhibitory concentration. Also, it is very less compared to pembrolizumab and nivolumab. That is, Pembro and Nivo requires 1.3 to 3.5 times higher concentration compared to tislelizumab. So these are the major clinical trials. I am going to talk about the gastric cancer only. These are the ongoing clinical trials with the tislelizumab, including other novel combinations across various phases of trials and across various countries and across various, along with the various agents. So this is the gastric cancer background, just outline. It is the fifth most common. It is according to Globocon 2022. So fifth most common cancer in the males, but in the females and both sexes, it doesn't make into the top 5 common cancers. So more than 90 to 95% of the gastric cancers are due to the adenocarcinomas contribute more than 90 to 95% of the gastric cancers, and other cancers you all know, like cyst and carcinoids, primary gastric lymphomas. So there are two types, intestinal adenocarcinomas. So these are the well differentiated and typically better outlook. But diffuse adenocarcinomas are poorly differentiated and has a pass rate of it and most difficult to treat than intestinal adenocarcinoma. So this is the rational 305 trial for gastric cancer and gastroesophageal, advanced gastric cancer and gastroesophageal junction cancer in first line with the combination along with chemotherapy. So this is the study design. Actually, histologically confirmed gastric or gastroesophageal junction cancer. The heteros should be negative, and measurable disease should be there, and performance status should be 1 or less. So no previous therapy for locally advanced unresectable or metastatic gastric carcinoma. No period therapy with the drugs like immune checkpoint inhibitors. So in treatment arm, the tislelizumab 200 milligram every 3 weekly given along with the capax or cisplatin 5FU combination. The control arm being placebo with the same combination, Gilax or cisplatin 5FU combination. The primary endpoint is being overall survival in PD-L1 positive patients and the ITT analysis set. Key secondary endpoints are PFS and ORR and durational response, DCR, CBR, and HRQL safety. So treatment is continued until unacceptable toxicity or disease progression. And patients are followed for safety and survival. Stratification factors are regions and enrollment, peritoneal metastasis, PD-L1 scores. So 5 is the set as the more than 5 or less than 5. Investigator choice of chemo. So these are the baseline characteristics. The PD-L1 less than 5 is all are equally distributed among the arms. So this is the overall survival for 3 years follow-up patients. So the PD in OS is 15% versus 12.9% in the placebo. So when the TAP score is more than 5, there is a slight increase in overall survival. Compared to it's 15 and 16.4. Progression-free survival and the tumor responses. So tislelizumab and chemo is associated with improved PFS, higher ORR, and more durable response when compared to placebo with the chemo. So safety and summary. Treatment-related adverse events were slightly higher in tislelizumab chemo arm. It's around 22.7 versus 14.6, which are serious TRAEs. So leading to discontinuation is actually double that of the placebo arm. It is 8.1% in placebo chemo and 16.1% in tislelizumab chemo arm. So this is the comparison of tislelizumab with the pembro and nivolumab in the setting. So it's almost equal, or it is ahead. It is 16.4 months median overall survival compared to 15.7 with the pembro and 14.4 with nivo in the same setting. So which is also comparable. So based on this, the first line combination indication has been included in the NCC. These are the this is a first line chemotherapy. This is so chemotherapy plus tislelizumab in first line gastric cancer and gastroesophageal junction cancer. Chemotherapy alone, compared to chemotherapy alone, produces a statistically significant, clinically meaningful improvement in survival, tumor progression, and response. Thank you. Sir, over to sir. You, sir. Prasad, sir.
Thank you, Doctor. Next, we will be having a quick panel discussion on how do we have the barriers broken in esophageal carcinoma, and especially the drug usage in this particular special field of oncology. So may I invite my panelists, please? Dr. Armugam, sir, are you there? Dr. Armugam?
He was there, sir. I'll just check. Meanwhile, you can invite the next.
Yeah, and Dr. Prasanna, Dr.
Yeah.
So there's going to be a quick presentation on what do we have in the field of our new oncology now that we do have this new drug. So what do we have for our patients is what we are going to discuss in the next couple of few minutes.
Yes.
Is my screen visible?
Yes, sir.
Thank you. So now that we initially started with many of the immunotherapy drugs, and now we do have tislelizumab across many indications in right from head and neck cancers to lung to GI, and also in hepatobiliary. So may I now ask Dr. Panditare sir, so in what proportion of the patients in esophageal squamous cell carcinoma or the GE junction do you do PDL testing? So do you do it routinely, or just how many patients also test positive if PDL1 is positive, sir?
Sir, actually, there are the two kinds of things. So in GH setup, we don't do. In outpatient setup, means outside practice, we usually suggest for advanced cancer patients. So whenever we do head to like a panel along with PDL1. So the cancer.
With that,
Yes, sir.
PDL1 and also the MSI status, and in
MSI.
MGL we get everything about that. So these are all the usual markers that what we routinely do. HER2 is generally for second line and beyond, and if HER2 is positive, we do have trastuzumab-based therapies. And if MSI high, we do have the role of immunotherapy, and we do have a lot of drugs for immunotherapy also. So now that we do have the management in the second line setting. So we do have the metastatic in the first line and second line setting, and we do have patients living longer after the initial treatment. Dr. Prasanna, are you there?
Yeah.
So how do you stratify patients based on this PDL1 CPS score, or would you just go ahead with the tumor area proportion score? So which would you think which is feasible and easy for the pathologist?
See, right now, the pathologists across the state do not have idea about the TAP score. Probably only in the academic centers they are trying to do a TAP score, and certain institutes do TAP score. But across the state, many centers, in private centers and also in a medical college setup, they do not know about the TAP score. So most probably they give a CPS score when we send a PDL1 for a GI malignancy. So as we know that there is a typical 95% concordance rate between with the TAP and the CPS score. So I think with CPS more than 10% or more than 5%, it concords with the TAP score more than 5%. So I take it as a positivity, and I would start a therapy with immuno.
It brings in the uniformity, I would say, tumor area proportion. With the positive staining, it is taken as positive instead of having this PDL1, CPS, TPS, and all these scores. So overall, this is what we are seeing in the new trial. In the tislelizumab trial, they had the TAP score, which typically corresponds with the CPS score also. So there is a good amount of overlap in the second line setting also, as well as in the gastric and the gastroesophageal carcinoma. So does the concordance data between the TAP and the CPS give you confidence in using tislelizumab? Definitely, yes, I would definitely go for that. Dr. Armum, are there? Dr. Armugam there? Or I would like to ask Prasanna again. Prasanna, for all the three clinical trial data that we had just discussed, so what would you have as a preferential use of tislelizumab in any of these settings? So there is a patient coming to you with for three patients, first line, second line, as well as the gastric cancer. Would you be comfortable using this data to use this particular drug in your clinical practice tomorrow morning?
Yes. Setting about the finances, we would be inclined to use tislelizumab, especially in PDL1 positive, CPS more than 5%, with TAP score positive, in first line esophageal squamous cell, and also when it comes to the gastric cancer. So we would be most probably inclined. When the patient is not being exposed to the first line therapy in esophageal, probably in the second line, we can use tislelizumab as a single agent.
Yes. What is your thought process, Dr. Padidare, sir? Dr. Panditare?
Yes, sir. Yes, sir.
So would you be comfortable to use this new drug in all these new settings, esophageal squamous, first line, second line, and gastric G junction adenocarcinomas also?
Yes, sir. Yes, sir. But the logistics is the only problem. If it is okay, and we have a data and we can try it out.
Hello, Dr. Prasad, I can Armugam.
Dr. Armugam. So
So
I would like to have your
with this available data, and there is no issue in using, means patient affordability is not the issue, we can go with this same drug.
So in the second line, so do you prefer immunomonotherapy, or would you like to combine with any of the chemotherapy partner? So how comfortable are you to use the immunotherapy drugs as a single agent, especially when tislelizumab? So if you could see in the NCCN guidelines for hepatocellular carcinomas, tislelizumab is approved as a monotherapy.
Yes.
So are we still good enough to use monotherapy, or we still would like to combine with any of the chemotherapy partners, which is not used previously in the second line setting? So what would be your line of practice, sir?
Mainly in the esophageal cancer, we should consider on the performance status of the patient. So if the performance status is good, we can combine with the tislelizumab with the chemotherapy, or otherwise we can go with immunotherapy alone.
Thank you so much. And any final thoughts I would like to ask Dr. Pandithurai, Dr. Prasanna, and Dr. Arumugam sir. So tomorrow, if finances are not a big problem, or even if there is no financial constraints, we'll take it as no financial constraints. Now that we do have access to all the drugs, Pembro, Nivo, Atezolizumab, Toripalimab, Tislelizumab, Serplulimab. So we have close to about Durvalumab, 7 immuno-onco drugs. So now that we had listened to all our speakers, and we do have our personal practices also. So if finances are not even a constraint, so why do you think, or how do you think we would accept this particular drug in our clinical practice? Dr. Armugam, sir?
Yeah, yesterday only I go through this my slide, so I thought and the results are also it's good. And only thing is it approved for the all the indication in India? That may be the one consideration. So in that slide, some indications are not approved in India. So that can be cleared by the company people. Then we can go with this drug with because of even Pembro and Nivo. Now Nivo generic is available, but Pembro I thought it may be the costly one, so can go with tislelizumab with available data. Which I went through yesterday. Yeah, what is the thought by Dr. Prasanna?
Yeah. The one thing is we have at least 5 Chinese immunotherapy molecules right now available in India. But many patients come up with NCCN guidelines with printout, especially when it comes to the gastric or esophageal or head and neck cancers or even lung cancer. So some patients are more skeptical towards starting Chinese molecule, but they want to stick to the innovators, especially the Pembro and Nivo. So that's the only set of patients I would set it apart. For all other general patients who are affordable, probably tislelizumab may be a game changer.
Dr. Pandithurai, sir?
Sorry, always anytime any new drug comes, if the logistics are not problem, I am ready to use. But just I want to ask one question to you, Prasad sir. Sir, do you have any real world data, sir? Any cases, case series of from your institution, like the results of?
So when this particular drug was launched, the first patient whom I had started was in hepatocellular carcinoma. Because in hepatocellular carcinoma, this was about middle of 2025. We had only 2 preferred agents, atezolizumab, bevacizumab, and tremelimumab and durvalumab. Atezolizumab was like super expensive, not much affordable. It was about 4 lakhs cost, and durvalumab was 9 lakhs. 2 lakhs, and tremelimumab was 9 lakhs. So the only option which I had was to use tislelizumab when we have all these molecules, and I used it.
Okay.
To my surprise, there was a very good response in this patient. Alpha fetoprotein started to decline. So that was my first patient with tislelizumab. And subsequently, when I started attending all these meetings and conferences and read about tislelizumab, tislelizumab is going to be the new pembrolizumab. It is indicated in across many of the sites. So, for example, there are many trials which are now happening in head and neck cancer, nasopharyngeal carcinomas, especially lung. It is proven both in adeno as well as squamous, esophageal both in squamous as well as in adeno, gastric carcinoma, hepatocellular carcinoma, and there are newer approvals for even rectal malignancy in NCCN. In metastatic colorectal malignancies, tocilizumab is given as a category 1 recommendation. So when we look at the inner details, so across all the subsites, it's indicated in bladder cancer. And when you just Google it, it is also showing up in renal cell carcinomas also. So it's like the most common tumors that what we see in all the sites, tocilizumab had been tested. We do have data for that. So pembrolizumab, maybe another couple of years, will be replaced by tocilizumab. That is my personal thought process. But we'll have to adhere with what the DGCA approves. But also when we are looking at the
So currently, it is approved by DCCA in esophagus, gastric, and lung. No, sir.
specific indications.
Okay.
But
Sir, what about the side effect profile, sir? It is like because it has an increased affinity and slow dissociation and slow clearance. So side effects would be, I thought more, but they have given it is.
attached to the T cells and the immune cells. But at least luckily in my practice, I don't see much of adverse events with any of the immunotherapy drugs.
Okay.
Outcomes are much better. Especially, I have gained confidence only with tocilizumab by using more in many of the patients.
So you are using the same dose, that is 200 mg.
It's a fixed dose, sir. Yeah, it's a fixed dosage.
Sir, they have given the 3 doses, 150 milligram every 2 weeks or
150,
400 milligram every 4 weeks also there. But you are using the usually trial the same dose.
Everything. Affordable and convenient.
What about the cost, sir?
I think it is 1+1. Alternate doses patient will buy for 1.2 lakhs for 5 paid doses. So totally it would cost somewhere around 6 lakhs.
6 lakhs.
6.1 lakhs. And the remaining doses for up to 1 year will be free of cost. So in a way, when pembrolizumab patient needs to spend 12 lakhs, nivolumab patient needs to spend 10 to 12 lakhs. Atezolizumab doesn't even come near to the costing. This is much more convenient for the patient. And obviously,
Only
as
6 lakhs and 17 doses. That's
17.
Good order.
So but you used in hepatocellular carcinoma, isn't it?
Yes, sir.
So ICC is a monotherapy. You used monotherapy because durvalumab, tremelimumab, IO, and IO VEGF. But here you are using only tocilizumab.
And now we don't have data with lenvatinib with tocilizumab also.
Tocilizumab. Okay.
IO
The
with
ongoing
TKI is
studies
also
are there.
available. So many studies. So that's what. So when I started reading about tocilizumab, it's coming up in all the indications. So that's going to be the next pembro. That's what
But
probably.
is it a molecule from China? Its origin?
Yes.
Okay.
Yeah, it is at least 50% of pembro rate. Then
50% of pembro, cost effective, and patients are able to accept and adapt it. So when we are looking at the patients are also very choosy, and they are also very scared at the same time. So when we talk about all these newer molecules and high cost, all the enthusiasm goes off. Most patients come to the clinic asking for the latest treatment. But when we say the latest treatment will cost 12 lakhs and we don't know whether it will work or not, the enthusiasm goes off. But at least in a way, the Glenmark had kind of made the access affordable. And I think there is one more patient support program where patient needs to buy 100 mg and the 100 milligram is free. So patient will spend only 65,000 rupees for one cycle, but patient will buy 10 consecutive doses.
okay.
65,000 plus a little bit of cost for the chemotherapy, which is staggered for all the initial 10 doses, approximately about 6 to 7 months. And then the remaining 6 months, immunotherapy is free of cost.
So the vial strength is 100 mg.
100 mg, sir. Yes.
Yes, sir. Sir, we do have three options, sir.
Hmm.
One is 1+1. If patient is buying 200 mg and next cycle will be free for 200 mg. And second option is patient is buying 5 cycle and rest of cycle will be free, sir. Rest of 12 cycle. And third option, Dr. Prasad sir said, if patient is not able to afford, and patient can buy 100 mg and same day we can provide the 100 mg also.
Okay.
In a way, we can
Sir,
still.
Prasad sir, any experience with previously Pembro and patient not affordable? Yes, same kind of patient is with me now. They elsewhere treated with Pembro and now not affordable after 2 cycles, and he came to me. Is there any data with the tislelizumab will work in this setting?
So, failed on an IO, I'm not sure how another IO might help.
Okay.
That we might need to see. But now the newer treatment options also depend upon doing the NGS. If we can look at the tumor mutation burden. And now I think one or two companies have, I think, recently started doing PDL2. So it is not just alone PDL1.
PDL1. Yes.
It is now PDL2, which is also getting recognized in immunotherapy. So sometimes PDL1 is negative, but the immunotherapy drugs works well. So, say for example, in the neoadjuvant setting of breast cancer, even PDL1 negative patients can get pembrolizumab. But how does the pembrolizumab work when PDL1 is negative? So the scientific data is not exactly through PDL1, but it also exerts its action on PDL2. That's the plausible explanation which is given. But immunotherapy is like we need to understand a lot more, not just the PD1, PDL1 interaction or the CTLA4 that what we know. It's much more complex, and probably we need to understand more about how our immune mechanism works, at least to understand whether post pembrolizumab will tocilizumab work. And there are also change in the structure of PDL1, I mean the tocilizumab. So binding to a different site. All these do definitely matter in terms of outcomes. So overall, we did have a interactive session. Thank you, Glenmark. And if there's any comments or anything, we'll be happy to have it.
Thank you. It's nice.
Thank you, Prasad.
Dr. Arnoga.
Oh,
Thank you, sir.
And thank you, Dr.
okay. As
Sir,
we
thank you,
come,
Prasad sir. It's a wonderful discussion, and I got some insight into tislelizumab. Thank you, sir.
okay, so as we come to the end of the today's insightful webinar on latest advances in immunotherapy, I would like to take a moment to express our sincere gratitude. We are truly thankful to our esteemed convener, Dr. E. Prasad sir, for guiding the scientific program with his expertise and leadership. A heartfelt thank you to all our respected faculties members for sharing their valuable knowledge and enriching the session. Thank you once again to everyone for making this session a great success.